Good evening, everyone. Welcome to First Aid AMC MCQ. This is Dr. Arshan, and I'll be the coordinator of the MCQ class that's going to start from 6th February. So do you guys hear me properly? I can see that some of you are in the Zoom session and some of you are in Facebook. Normally, we don't take any class on Facebook Live, but because this is the first few sessions with us, we would just also do it on the Facebook so that some of you might not understand how to join Zoom classes. So in that case, you can just hear us or see us in the Facebook Live. But please be reminded that we don't take classes on Facebook. Just for the few review sessions that we are going to take this month and also the coming month, that will be also on Facebook as well as in the Zoom. But I always encourage the students to come over to the Zoom session so that we can make the class only centered in one particular place rather than I am going to the Zoom and then going to the Facebook. And that's how we can just waste a lot of time, nothing else. All right, so you guys can hear me properly, I can see. What kind of, you guys can hear me properly, right? No disturb in the background or anything like that, especially for Facebook. If you guys have any question, anything, feel free to write me in the chat box in Zoom. And also you can also write it in the comment box in Facebook. And I'll just look around in the comment box. In case you have any question, I will also try my best to answer it. Okay, now the important thing is that AMC MCQ is your first step to reach your dream towards being a doctor in Australia. And I know that how hard it can be initially, just thinking or making a peace with your mind that yes, I'm going to work in Australia one day. And that's how all of you started your journey. And you're going to have an amazing journey towards being a doctor in Australia. And First Aid AMC MCQ is one of the most famous, I would say, famous online course that we are taking it for the last 4 to 5 years. And throughout these years, we have helped a lot of candidates to reach to their dream. And we can see now that every month, a lot of candidates are passing from the course, some passing from MCQ, some covering their clinical, some getting job eventually. So that's how step by step you guys are also going into that direction. I always tell my students, think what is in your present at the moment. Your present goal is to pass MCQ, nothing else. You don't think too much about job. You don't think too much about clinical. You don't even think about passing English test because that's not what you need to think right now. If you know that you are going to be a doctor in here, then your first thing to think about is passing the MCQ first. You pass MCQ, then you think about the next step. But saying so, you should always have a background idea about what is going to be your journey. Now, the journey is pretty simple. Like saying so, it's simple, but it's not very easy to get. But obviously, with a lot of hard work, a lot of passion, and understanding things properly, you will end up getting into that dream that you are having. So I'm going to give you just a very little idea that what you should expect in this journey. And then we are going to start our review session on psychiatry today. So in case of being a doctor in Australia, the first thing is you pass MCQ. After passing MCQ, you should pass clinical. Some can also go for the English test. And then with AMC, MCQ, and English test, you can start applying for the job. It's hard to get a job just by passing MCQ, but it's not impossible. People get it. And then obviously you need to also pass your MCQ. So 3 things that is needed to apply for a job. Either you go for part 1 and English test, apply for job. If you're not getting job with part 1, then also you will, at the time of applying for the job, you will also do your clinical preparation, finish the clinical preparation, have your English test done, again go for a job. Having all this sorted out, like passing MCQ, clinical, and having an English test which is valid, your chance of getting a job is very, very high. Now, I'm not going into the direction of where you are going to end up after getting a job. Just remember, there are 2 pathways in Australia to be a doctor in here. One, you end up in a hospital as a junior doctor, and then you go for, throughout the years and years, you being a specialist, or start being a junior doctor, you become a registrar, and then you become a specialist. Or there are other pathways. You start your journey towards a general practitioner, start as a junior doctor over there, pass their RSCGP exam or GPS specialist exam, and being a GPS specialist. So that's how these things are going to work, guys, for you. So you don't need to think in that direction at the moment. Only thing that you think now is how I am going to pass my MCQ exam. If you are having this knowledge in your behind, you will end up having everything sorted out. Don't listen to anyone that it's very hard to pass clinical, it's very hard to get a job, it's very hard to get a visa. No, don't think anything about it. If your mind's saying that, yes, I can do it, you do it. All right? So never ever listen from someone who was unsuccessful. There are candidates, there are people who will be unsuccessful, who might not get a job, who might not even get a job after passing clinical. But there are people, thousands of people who are getting job with MCQ also. So you think that you might be that person, not the other person who is unlucky to get that job. So always be with someone who is supporting you in a positive way. You don't need to think about the negative all the time. With hard work, if you believe in yourself, if you believe in your higher power, then yes, you will reach that destination one day. So you just need to hang in there. Okay, so that's all about the chit chat today. We're going to start the review session on psychiatry. I hope you guys enjoy it. Before moving into the psychiatry, let me give you a little bit idea about the MCQ format. AMC MCQ is a computer adaptive software-based exam, which means that you have to be in a center where you can give the MCQ. And in that center, you will sit there, there will be a computer, and then from question 1 to question 150, there will be 3.5 hours time. You will sit in front of a computer, and then you will just finish your exam. So 150 question, 3.5 hours, computer-based exam, and you have 120 question which is scored and 30 questions which are non-scored or pilot. You don't know which one is scored and which one is pilot, so every question is important for you. But we know that the last 20 question is always a scored question, so please remember that 20 question never ever is a pilot one. Try to get it correct. And to get the exam result, you have to finish 150 question. If you don't finish it, then you don't get your result. That means you will get a result as a fail. So you have to finish 150 question, whatever it is. If you're running out of time, at least just click anything, any option, but click on the finish button at the end of your 150 question, and then at least your exam will be marked. Otherwise, it will not be marked even. So that's a very important thing to know about. What is the past score? 250. Now, this scoring system it's still an illusion to almost everyone. No one knows how they score you. It's not like every question is marked as 1. No, some questions are marked as 2, some questions marked as 4, 6, 8, some question even 10. So based on the difficulty level, the software will mark you in the exact similar way. So no questions are marked similarly like your other exam. So that's why no one knows what question carries what mark. So that's why it's very important to give enough time in your exam to know that, to give a correct answer. Other important changes to the AMC from the last year is that previously you could get a flag option in your exam. Flagging means that there was an option at the bottom that if you are not sure about the answer that you are taking, you can flag that question, and at the end of the exam, you can come back to that question. But that's no longer an option, that's out. So now you don't get to come back to your previous question. Once you are done with one answer, that's the answer. You can't change it back. So that's very important to remember. So sometimes it might be a little tricky. Like sometimes pilot questions are quite difficult, and you can end up wasting a lot of time just with one question. But you can't do that because the time that is given to you, it's not enough for the exam. And if you waste a lot of time with just one question, you will not be able to finish the exam in the due time. That's why if you're not sure about a question which seems to be very difficult for you, most likely it's a pilot question. Don't bother too much with that. Just answer any of those options and go to the next question. Okay, because you don't need every question to be correct to pass this exam. As long as you are in here in the 250 zone, you are good. So you can see the passing score is 0 to 500. As long as you are here at 250, you pass the exam. All right, so that's a little bit idea about your AMC MCQ. Now let's move on to psychiatry. If you guys have any question during the discussion, let me know. I'll be very happy to answer any of your questions. First of all, what books are needed for your psychiatry preparation? For psychiatry, remember one thing, one of the hardest topic in your exam will be psychiatry, and it is one of the most important one. And because most of you will never ever read anything in your medical university about psychiatry, so it's hard for you because this is a total new thing for most of you. So that's why you need to know the basic pretty well in here. And without having a basic, if you just solve some questions that you are getting from somewhere, it's not going to help in the exam. Questions will change. So always make sure psychiatry basic should be really, really good. And we are going to help you with that. So what are the books that you need for psychiatry preparation? You will need JAM 8th edition. So now it's not 7th edition anymore. So we have got the 8th edition. So JAM 8th edition, then you'll go for Kaplan Step 2 CK. We always take help from JAM and Kaplan Step 2 CK most of the time. So these are your two most important books. And also you can take help from some of the websites like Range CP and Medscape. Not very, very important, but the very important way to learn psychiatry is UWorld USMLE. You don't need to go through a whole lot of UWorld USMLE, and only the important topics that we are going to touch in the psychiatry class, you just need to go through that from your UWorld. And we'll give that link of the book to you in the Facebook group. And obviously, you will take help from our lecture notes. There are psychiatry question solvation files we will be giving to you. So that psychiatry question solvation file, we will discuss some of the questions after we finish total psychiatry. And then we will discuss those questions with you. And you can also go through the whole whole like 150 to 100 questions that you can have in a psychiatry file. So that's how you prepare. Your preparation always should be starting with a theory and followed by solving some of the questions. You can take help from QBank. You can take help from our question solvation files. So any question solvation, if you do, that's important. But do not start with QBank first. A lot of you wants to make it very quick one. Remember one thing, that learning is not, never ever learning is very cheap. Learning is not very quick. You have to learn the basic, obviously, to answer anything properly. And if you think that I'm going to finish the exam in 2 months or 3 months by just solving some QBank, no, you're going to end up going for exam multiple times. That's not needed. Please do not do that. And if someone is saying that to you, they are obviously directing you to a wrong path. So these are your books for your psychiatry preparation. Now let's start. So first of all, we are going to start with depression. For depression, the important thing is understanding the definition of major depressive disorder and how to differentiate with grief, complicated grief, or bereavement. Now, major depressive disorder, have a look at the question first. A 70-year-old woman was recently admitted after her son informed the doctor that she had been doing very poorly over the last few months. The patient reports a 30-pound weight loss, decreased concentration, helplessness, hopelessness, decreased energy, depressed mood, and decreased sleep. All of these are criteria of MDD. So DSM-5 criteria to diagnose major depressive disorder is if anyone have at least 5 of the following symptoms persisting for more than 2 weeks, that's MDD. So the duration is important. It has to be at least 2 weeks and 5 of the 9 symptoms in here. So what are those symptoms? First, depressed mood, loss of interest or pleasure. We also call it anhedonia. Change in weight or change in appetite. Change in sleep. Sleep change can be insomnia or hypersomnia. Psychomotor agitation or retardation. Psychomotor retardation means patient gets slow with everything. And agitation means patient gets agitated, restless, irritable, or with all the things. Loss of energy, feeling of worthlessness or guilt, loss of concentration, and suicidality. If anyone asks you what is the most important question you should ask to a patient who is suspected to have major depression, what is your answer, guys? Yes, number 9, suicidal ideation. That's the most important question that you should ask. In your exam, you will get a lot of questions, and understanding what they actually ask to you, that's also important. We will have another class on some practice question solvation in the next week, 30th February, and you will see that how questions come in the exam and what you really need to pick up from that particular question. Okay, so you will get to know about it in the next class. So these are your 9 major depressive criteria. Out of this, if 5 are there and it's persisted for 2 weeks, that's, you can diagnose that patient with a major depressive disorder. Sometimes they ask which criteria is essential to diagnose a person with major depressive disorder. The criteria which is essential to diagnose MDD is number 1 and number 2. So low mood and loss of interest, These two is the most important, you can say it is the most essential criteria to diagnose someone with MDD. So understanding what they're asking is also important. If they're asking what is the most essential criteria, that becomes either one or two. If they're asking what is the most important thing you are going to ask, that's suicidality. So that's important that you understand the question. Now, how we remember these 9 symptoms, that's using this M Psych caps mnemonic. So M for mood problem, so low mood. S for sleeping issue, either insomnia or hypersomnia. Then I for loss of interest. G for feeling of guilty. E for loss of energy. C for loss of concentration. A for loss of appetite. P for psychomotor retardation or agitation, and S for suicidal ideation. So if you just remember M Psych caps, that's how you can easily remember MDD. Sometimes they ask that what is the atypical symptoms of major depressive disorder? Atypical symptoms of MDD is most of the depressed patient will have sleeping difficulty like insomnia, but atypical symptoms is hypersomnia. Most of the patient will have lack of appetite and eventually they will lose weight. But atypical symptom is increasing appetite and increasing weight. So these are your atypical symptoms of major depressive disorder. Same with the psychomotor agitation, that's atypical symptom. Whereas psychomotor retardation, that's your normal symptoms or typical symptoms. So these are the 2 key criteria for major depressive disorder. One is depressed mood and another is marked loss of interest known as anhedonia. There are some classification apart from just major depressive disorder. So we have got persistent depressive disorder or PDD. So if you're having depression for constantly for 2 years, that becomes PDD. So we call persistent depressive disorder as sometimes as a dysthymia. So PDD refers to a long-standing 2 years or more depression of mild severity. Now, does major depressive disorder patient can have psychotic features? Yes. Psychotic features means patient with depression seeing something unusual, like having a visual hallucination or hearing some voices, like that's what we call as auditory hallucination. So if someone with a major depression having psychotic symptoms, that is what we call as major depression with psychotic feature or major depression with psychosis. And that's the worst prognostic criteria for someone having depression. So sometimes they ask in the question that what is the worst prognosis for someone having a major depressive disorder? That's your question. That's your answer, that if someone having associated psychotic features. And these are your atypical features: increased weight, increased appetite, and increased sleep. Now, we were discussing about major depressive disorder in adult. How about depression in children and adolescent? Depression in children and adolescent is a little different from how it present in an adult population. Adults become more sad and feel low, crying episodes, whereas children and adolescent, they usually don't cry, but they become irritable, they become restless. That's one of the important criteria. They also can have feeling of helplessness, worthlessness, but they don't have sad mood or low mood. They also have loss of interest in their usual activities, and they can have an irritable mood persisting for 2 weeks or more. As you can see, in children, irritability may be more prominent than sadness. Other than that, they can have difficulty going to sleep, not enjoying their meals, poor concentration, getting low mark in their exam, having a downgraded school performance. All of those things can be a presentation of depression in children. Next, what is recurrent brief depression? Some patient can have recurrent episode of depression, but that's only for a short duration, like less than a week time. To diagnose someone with a major depressive disorder, it has to be more than 2 weeks. But if someone having features of depression and having it recurrently, like almost every month, but it's very short duration, 3 to 7 days, that's what we call as brief depression or recurrent brief depression. In these patients, medications like antidepressants are not that effective. So an alternative medication for this population is lithium for long-term use. And initially, you can just start with some psychotherapy like cognitive behavioral therapy. We are not still into the treatment, so we'll discuss that later on. But remember, antidepressant is the first-line medication for major depressive disorder, but for recurrent brief depression, it's not that effective. Lithium is the effective one. There is also seasonal affective disorder. That's mainly some people have winter blues, like those who live mainly in the winter season or cold climate, they get more depression during the winter time. And that's what we call as seasonal affective disorder. Treatment is psychotherapy, sometimes phototherapy, and even medication. Now, let's move into the management of depression a little bit. To go into the management of major depressive disorder, first you need to know the type of depression. There is mild, moderate, and severe depression. Mild, moderate is like it's not affecting the patient's life too much, and the patient is not really not very severely sad. And the most important thing is that they are not having any suicidal ideation. If someone having active suicidal ideation, or if it is affecting their life immensely, that becomes severe depression. There is no particular criteria to diagnose someone with mild, moderate, and severe. But just remember, if someone is not ideation, not affecting their lifestyle, then it's not severe, it's mild to moderate. For mild to moderate depression, you should start your treatment with psychological therapy, which is mainly starting with cognitive behavioral therapy. So what is CBT? CBT is a kind of psychotherapy in which counselor or a psychologist will talk to the patient, listen to their problem, and will try to convert their negative thought into a positive one. And that's how CBT works. This is the best management for almost a lot of psychological condition. So that's your first line treatment. Never ever just start with antidepressant for anyone. If it is severe depression, yes, then you should start with antidepressant, and first line antidepressant is Ssri. If along with the antidepressant, you can also consider addition of a psychological therapy. If it is very, very severe depression or depression which is not even controlled by medication, patient having psychotic features, then yes, the last option is electroconvulsive therapy. Okay, now let's have a look at this question and tell me what you think about the option. So a 72-year-old man comes to the office due to worsening depression and insomnia since his wife died 7 months ago. The patient experiences lethargy and episode of tearfulness. He has little interest in socializing with his friends anymore. He has attended 3 sessions of psychotherapy and expressed the appreciation for the referral because he likes the therapist. However, the patient continues to feel depressed, experiencing severe insomnia, having difficulty falling and staying asleep. He feels very guilty about her death. The patient experienced a moment of severe depression last week in which he briefly thought about suicide. Physical examination shows loss of weight. Which of the following is the most appropriate next step in management of this patient? Now, first of all, is it depression or complicated grief? Always remember, you can't say that it's complicated grief if someone having the features of major depressive disorder. If the major depressive disorder criteria is fulfilled, that's no longer complicated grief. Okay? Now, what is complicated grief? Complicated grief means when someone loses someone who is dear to them, like a husband has lost his wife, something like that, the natural grief period will be up to 6 months. When it even persists more than 6 months, it becomes complicated grief. But those patients does not fulfill the criteria of major depressive disorder. At any time they fulfill that criteria, the diagnosis becomes MDD. Now, if you look at here, this patient having all the manifestations. So you can see lethargy, so loss of energy, episode of tearfulness, that's obviously low mood, loss of interest, feeling depressed, also low mood, severe insomnia, that's sleeping problem, feeling guilty, suicidal ideation, loss of weight. So 7 symptoms are already here, right? So this patient is mild, moderate, or severe depression. That's the question. Severe depression, right? Good, because patient had a suicidal thought. Now come to the option. Increase frequency of psychotherapy to twice weekly. Prescribe amitriptyline. Amitriptyline is second-line medication for depression. That's a TCA, tricyclic antidepressant. Prescribe mirtazapine and continue psychotherapy. Prescribe zolpidem for insomnia and continue psychotherapy. Provide reassurance, continue psychotherapy. Recommend ECT. Now, the most important thing to understand, first rule out what is very unlikely to be your answer. So this is a severe depression, only psychotherapy will not be helpful. So cross this out, and ECT is not needed unless you try any medication. Now you have B, C, and D. Zolpidem is a medication for sleeping, or you can say it's a kind of sleeping pill. We never ever give sleeping pill for insomnia when insomnia is a part of depression, because you can help the patient to sleep with zolpidem, but what about the other symptoms? So you rule out it. Never ever give sleeping pill or choose an answer in your exam where sleeping pill is an option. It's very unlikely we offer sleeping pill in Australia. Now, obviously, you do understand that amitriptyline and mirtazapine, the best option is SSRI, so that's your mirtazapine. We'll not try amitriptyline as our first line. So C will be your correct option in here. And also mirtazapine is a sedative kind of antidepressant. So this patient having sleeping problem, with mirtazapine, that will be also dealt with. Now, next is side effect of this SSRI medication. commonly comes in exam. Psychiatric medications, you need to know a little bit more because a lot of time you will end up getting questions related to the side effect of the medication. So common side effect of SSRI is insomnia, sedation, change in appetite, nausea, dry mouth, headache. Sexual dysfunction is very important one. And also a lot of other things can be there. You can give it a read by yourself. Now, two questions which is important for your exam. We'll go through that just a little bit. Have a look at the common SSRI side effect for each of these medication. So you know some of the SSRI, which is fluoxetine, citalopram, escitalopram, sertraline, paroxetine, fluvoxamine. Now, these are your common side effect. You can see that most common side effect is nausea for any SSRI. Then you have all this headache, insomnia, drowsiness, diarrhea, tummy pain, sexual dysfunction, a lot of things. Always remember, sexual dysfunction or erectile dysfunction is a very, very common side effect of SSRI. And almost every SSRI can cause it. So there is a question comes in exam asking you about SSRI side effect. Like let's say you have started a patient with 100 milligram sertraline. Okay, and just after starting it, in 2 to 4 weeks time, patient is started to get the sexual dysfunction. Your options are, one option that you can reduce the dose. Another option is keep on giving this medication because most likely it will get better once patient starts taking it for a longer period of time. So you want to wait and see. Another option is to change the medication to another SSRI. Another option is, let's say that change to other antidepressant, which is not SSRI. Or you want to give some erectile dysfunction medication like sildenafil or Viagra. So these are your options. What do you want to do? Now, the most important thing, you look into the question that what is the symptom control of this patient? Most of the time in the question, they will write to you that patient depression is better now after taking this medication. If after taking 100 milligrams sertraline, patient symptom of depression is better, but patient getting sexual dysfunction, what you can do, rather than doing anything, you can reduce the dose to 50 milligrams sertraline and see how the patient feels with the symptom control. Okay. Now, obviously, if patient is feeling better with 100 milligrams sertraline, then only you can choose it to reduce to the 50 milligrams sertraline. But let's say in the question, they say that patient is still not feeling 100% all right after taking this medication. Now, in that case, obviously, you can't reduce the dose. So that option is gone. And always remember, sexual dysfunction does not get better with wait and watch approach. So that's out. And as I say that almost every SSRI can cause sexual dysfunction. Changing it to another SSRI will not be a good idea. So rule that out. Now options are 4 and 5 at that time. Before adding sildenafil, always try to change it to another antidepressant which causes less sexual dysfunction. Okay? Is this clear, guys? Among the lowest rate of sexual dysfunction, the antidepressant that you have got, that's one is bupropion. Another, sometimes mirtazapine is also a good one. So if changing to mirtazapine is the option, you can choose that. And there are also some very unusual name you can remember, which you don't need to. So just remember, sometimes nefazidine, vilazodone, those kind of drug we can use, but it doesn't come in the exam in that way. So just remember that do not change it to another SSRI because that doesn't help. Now, if even after changing to another antidepressant who has lower chance of sexual dysfunction, patient is not getting better, then your option is to add sildenafil. So never ever just give Viagra to anyone. Okay, first try with this simple approach first. Another question comes, a patient you started with sertraline, started to get nausea, vomiting, tummy ache. What do you need to do next? And that's a tricky one. That's a question in your handbook. So if you go through your psychiatry handbook questions, you will find out this question. Now, different SSRI has different kind of nausea, vomiting, or tummy upset criteria. So in that particular side effect, if one SSRI causing tummy upset, you should change it to another SSRI. Okay, like you can change sertraline to fluoxetine or sertraline to paroxetine and see that how the patient is feeling. So that's one of the other thing that you need to remember from this side effect part. Question comes that what is the most appropriate antidepressant for depression in adolescent? Anyone? Yeah, so fluvoxamine or fluoxetine, these are the two best medication or SSRI for someone who is having major depressive disorder, but it's a child or adolescent. So children or adolescent, if you want to start SSRI, you choose either fluoxetine or fluvoxamine. Okay, now these are the mirtazapine side effect. Always remember, mirtazapine is highly sedative drug. So severe sedation, constipation, drowsiness. It can increase your weight because you're sleeping a lot. So weight gain, increasing serum cholesterol, these are side effects of it. Venlafixin is another kind of antidepressant. So one is SSRI and another is called SNRI. So this SNRI is venlafaxine and desvenlafaxine. Venlafaxine also is a very commonly used kind of medication. But the side effect is important to know because sometimes questions come from here. And it's a very commonly used drug in Australia, known as Ssri in here. So what are the side effects? GIT side effect is common, but it's very notorious to cause insomnia. And also it can cause sexual dysfunction. It can cause weight loss, loss of appetite, headache, nausea. But the most important is these three. It causes increased blood pressure. So you can't give it to someone who is already having hypertension. It increases the risk of seizure. So epilepsy patient, you can't give it. Increase the risk of suicidal thinking in children. So it's not like someone having suicidal thought, you can't give Ssri, you can give it, but if you give, you need to do repetitive follow-up. so that patient is not getting increasing suicidal thought after you start Venlafixin. The most important side effect from all the SSRI is this one, comes in exam frequently, known as Serotonin Syndrome. So if you are taking 2 or more serotonergic drug, then in your blood, there will be a lot of serotonin and you will get serotonin syndrome. So let's say someone can get serotonin syndrome either with introduction of a new SSRI on the background of a existing SSRI. Like, let's say you have got a patient with depression and you started SSRI because patient having severe depression. Let's say you started sertraline. And this was your first patient, never ever you knew this patient. And this patient did not tell you that if she is on any other medication. And you also did not ask it. And you ended up to find out, maybe you checked the previous prescription and you find out that this patient is already on paroxetine. Now, if you would not check it and you have given both sertraline and patient already taking paroxetine, what you are doing? You are giving 2 SSRI to this patient and patient will obviously develop serotonin syndrome. Or sometimes patient can take an increasing dose of 1 SSRI that can cause it. Now, let's say you haven't given any SSRI, but you have given some other thing which can increase serotonin in the blood. Like you have given other antidepressant like TCA, amitriptyline, or any other tricyclic antidepressant. Or you have given opioid, especially for painkiller, you have given tramadol. Any stimulant drug, illicit drug like ecstasy. You have given antiemetics, lithium, or selegiline. Any of this medication can also increase serotonin in the blood. So you have to just find out in the question that if this patient is on any kind of medication which can increase serotonin level in the blood. What symptoms you get from serotonin syndrome? Mental problem, or you can say CNS symptom, which usually patient will get confusion, agitation, and even seizure, and altered mental status. Then altered muscle tone, so you will get tremor, shivering, myoclonus, and hyperreflexia. It's a very important finding. And obviously autonomic instability like hypertension, hypotension, tachycardia, high fever, and diarrhea. So this is exactly how it looks like. If you get a serotonin patient, you will find out patient having high fever, sweaty. If you look into the pupil, there is mydriasis, so dilated pupil. And because of autonomic hyperactivity, patient usually get hypertension, tachycardia. Because of increased autonomic hyperactivity, increased peristalsis causing diarrhea. And they will also get increased muscle tone, hyperreflexia, and tremor. So fever, tremor, hypertension, hyperreflexia, that's your serotonin syndrome. How you treat this patient? Anything which can increase serotonin in the patient, you have to stop that immediately. Now, normally we don't stop antidepressant like this because we need to taper it gradually and then stop. Otherwise, patient will get withdrawal symptom. But in someone who is having serotonin syndrome, you have to stop it immediately and refer the patient to the emergency department. All right. Now, sometimes serotonin syndrome can be confused with another syndrome known as neuroleptic malignant syndrome. And neuroleptic malignant syndrome occurs with taking antipsychotic medication. And that's we give for someone who is having schizophrenia or acute psychosis. So after taking antipsychiatric drug, patient can get a syndrome known as neuroleptic malignant syndrome. In that case, patient will also get fever. Patient usually get a prolonged course of illness followed by rigidity of the muscle, decreased reflex, and normal pupil. So that's how you differentiate. Even if you don't know which medication this patient is on, even by looking at the finding, you will know that what was the underlying cause. Is it the antidepressant or antipsychiatric? So that's how we differentiate between these two. You will get hypertonia and tremor in serotonin syndrome. But in case of neuroleptic malignant syndrome, you will get muscle rigidity. Reflex will be increased in here, decreased in here. Pupil will be dilated in here, normal in here. All right, so that's your serotonin syndrome. Very, very important for the exam. Understand it properly so that you can answer it. Now, once you start someone with antidepressant, how long you continue it? It is recommended to continue it for a minimum of 12 months for someone who just got the first episode of depression. But if someone having subsequent episode, then you should continue it for 2 to 3 years. And these are the risk factor of relapse. Okay, so that's your depression. Everything that you need to know about depression, that is here. You don't need to go through anywhere else. Any question with the depression, guys? We don't give the MAO inhibitor anymore, Dr. Ed. So it's no longer a medication of choice. So never ever we would give it. No, you will get access to the notes once you start joining our paid session. Then yes, you don't need to write anything. Now, major depression in pregnancy is one of the complicated management issue, and it is usually dealt by some specialists, especially who are obstetric medicine or obstetric psychiatrist specialists. They usually deal with this sort of patient. In those cases, it depends on, we try not to give any medication to them unless patient is severely depressed. And if they're depressed, we can give any antidepressant, like any SSRI is safe to be given in pregnancy, but we just try not to give it. Okay, but if someone is having severe depression, suicidal thought, then yes, we have to give it. Yeah, SSRI is safe. Like, still, if you search it in the Google or in any of the Australian guidelines, they usually say that it is well researched yet that if SSRI is safe in pregnancy. But if someone need it, then yes, we have to continue it even if they are already taking it. So the question is, like, if patient is already taking a SSRI and now became pregnant, and without the medication, patient can become severely depressed, then yes, we will continue it. And another question is that patient had a perinatal depression 2 years ago when she was pregnant. Now patient became pregnant again. Last 2 years, she did not take any SSRI or any antidepressant. What do you want to do now? In that case, you don't need to give any medication now. You just follow up the patient regularly and see that if patient needs antidepressant or not. If doesn't need, you don't give it prophylactically. Yeah, keep under observation. No need of thinking about the ECT immediately. ECT is usually important for postpartum women who is having severe psychiatric problem. Like, let's say someone having postpartum psychosis, then ECT will be an option at the end. Okay. ECT is never ever the first choice. We always start with some medication. If that's not a possibility, or patient is not taking care of it, patient is not taking medication, yes, then we have to go for it. Same with the pregnancy as well. We try with the medication first, but not possible, then ECT. All right. Now let's move on without a break. We might need to take a break after a little bit. So let's move on with the bipolar disorder. So what is bipolar disorder? Now we have been discussing about depression so far, right? So if you draw a line like this, and that's your normal mood, depression means you are going down, and mania means you are going high like this. Bipolar disorder means a patient who is having mania sometimes and having depression sometimes, which means they are having frequent mood swings. Okay, and sometimes even they will have a normal functionality as well. So when someone having both manic phase and depressive phase, and together we will call it as a bipolar disorder. What is the DSM-5 criteria for manic episode? If someone having at least 1 week of abnormal, persistent, elevated mood, which is euphoria, and along with the highly unusually, or you can say unusually elevated mood, patient also having 3 or more of these features. One of them is high self-esteem or grandiosity, decreased need of sleep, very talkative and loud flight of ideas like speech, patient having racing thoughts or flight of ideas, which means patient is just can't keep thinking about one topic. Their topic of conversation jumps from one topic to another. So that's why we are calling it as a racing or flight of ideas. They will be very destructible, increased goal-directed activity. That means a patient who doesn't do any work, suddenly they started to join a lot of community club, science club, football club, swimming club, and doing a lot of goal-directed activity. And that means that's something unusual. Okay. And excessive activity with painful consequence, which we actually say that having more impulsive behavior, like having uncontrolled gambling, uncontrolled drug abuse, uncontrolled sexual drive. So those are the symptoms of a manic phase. And the duration should be at least 1 week to say that it's manic phase. And along with that, the symptoms should be severe enough to affect their social occupational life, and sometimes also need for hospitalization. There is another term known as hypomania, which means the exact similar symptoms will be there, but the duration will be less than 1 week. And it will not be severe to interrupt their social, personal, or occupational life. So mania, hypomania, duration is very important to diagnose it. How we remember these symptoms? By this mnemonic called dig first. D is distractibility, so patient is poorly focused. I for insomnia, G for grandiosity, so high esteem, and they think that they have a special power, something like that. Flight of ideas, or thought racing, increased activities, which is mainly goal-directed. Speech will be pressured speech, rapid, talkative, loud speech, and T for thoughtlessness, which means risk-taking behavior. So if 3 of these symptoms are there, along with elevated mood, you can diagnose that patient with mania. Now, there are 2 types of bipolar disorder. One is bipolar 1, another is bipolar 2. What is the definition of bipolar 1? A mood disturbance in which patient typically experience symptoms of elevated mood for at least 1 week that cause significant distress in their life or in their level of functioning. Bipolar disorder has 1 fully fledged manic episode. So the important thing is, if someone having manic episode with that depression, that's bipolar 1. Someone having hypomanic episode and never ever had manic episode with depression, that's bipolar 2. So hypomania with depression, bipolar 2. Mania with depression, bipolar 1. Have a look at this question. A 19-year-old college student is taken to the school counselor after he fails several classes. The patient is enrolled in numerous classes, most of which have conflicting times. So you can see a lot of goal-directed activities. His grades are poor, yet he seems undisturbed by this. He is also enrolled in numerous organizations like chess club, drama club, student government, sports, and 2 fraternities. His speech is pressured and having psychomotor agitation. So you can easily understand that this is not something which is usual for this patient, and that's mania. Okay, but we will be able to diagnose it properly if there was a duration given in here. Does bipolar disorder has genetic tendency? Yes, there is a chance that if family history of bipolar disorder is positive, it is a high chance that their children will also get it. We already know about the behaviors of many people. Hypomania, we already know. Management, very, very important. Acute mania is always a medical emergency and it requires hospitalization. Now, if patient does not want to get admitted, can you admit this patient? Yes, because this patient, when having mania, does not have insight. And a person who doesn't have insight doesn't have the capacity to give consent about their treatment. And in this particular case, this patient does not have that capacity. And even if he does not want to get admitted, you have the right to admit the patient as an involuntary admission. What is the most effective treatment for acute mania? Antipsychotic. Previously, we used to give lithium for treating mania, but we still do, but that's as a prophylaxis. But for someone who is having acute mania, the first-line treatment is antipsychotics. And what type of antipsychotic? Not the typical one, atypical one, or you can say the second degree one. So like you can go for either olanzapine or risperidone. Second line would be other antipsychotic like haloperidol, aripiprazole. Even lithium can be given if you can't give any of the antipsychotics. Sometimes even a mood stabilizers like sodium valproate, carbamazepine can be given. But these are usually not your first line treatment. Now let's say patient is aggressive and you can't give oral antipsychotic. What else you can go for? You can give haloperidol IM or IV. So if antipsychotic drug, you need parenteral route, then you can choose haloperidol. Now, in acute mania, antipsychotics are the choice of medication. But for prophylaxis of recurrent bipolar disorder, you have to give something for a long time. 90% will have recurrence. So if someone have a 2 or more episode of either mania or depression in the past 4 years, that patient should get a prophylactic medication. A recommended prophylactic agent is lithium. And sometimes if you can't give lithium or patient can't tolerate it, then you have second generation antipsychotic agents. You can give any of the olanzapine, risperidone for the long time. Lithium should be used for a long term, like at least 3 to 5 years in this patient. And because lithium has very high chance of toxicity, always make sure you need to keep the plasma level of lithium in a target 1, which is 0.6 to 0.8. So anyone having chance or showing symptoms of lithium toxicity, you have to measure the lithium level as well. So what are the side effects of lithium and what are the toxicity symptoms? The side effects are it can cause tremor, muscle weakness, GIT symptoms, hypothyroidism, and nephrotoxicity. Very important side effect. Now, toxicity, mild means patient having GIT symptom, nausea, vomiting, sometimes even muscle-related hypertonia, hyperreflexia, tremor. Moderate, patient get rigidity, hypotension, hypertonia. In severe, patient get cardiovascular collapse or neurological involvement like seizure or coma. Now, in case of mild case or mild toxicity, you can just stop lithium until the lithium level comes back normal. And patient with lithium toxicity, they can get dehydrated. So you can start with some IV normal saline. Okay. Now let's say if someone has developed cardiovascular collapse or developed seizure, coma, or if the lithium level is more than 4, what will be your treatment at that time? Anyone? Yes, let's say you have stopped lithium, but at that time, just with stopping lithium will not be helpful. You have to do something. So if someone with a lithium toxicity having cardiovascular collapse, neurological symptoms like seizure, coma, okay, in that case, yes, you stop medication, you resuscitate the patient, but also you need to start the patient with dialysis. Okay, that's the treatment. So lithium level more than 4, patient having severe symptom like cardiovascular collapse, renal failure, or neurological features, that patient will need dialysis. Another thing, if you get a patient with depression and you start with antidepressant to that patient, but you did not know that this patient had a chance of having mania previously. Sometimes giving an antidepressant to a patient with bipolar disorder can precipitate an attack of mania. So that's why, that's usually we call it management of bipolar depression. If someone having bipolar disorder and now currently is in the depressed phase, you can't just give antidepressant, because if you just give the antidepressant, you will precipitate an attack of mania. So for them, the recommended regimen is you have to give both antidepressant and an antipsychotic. So this is a difficult component to treat, and antidepressant should not be used alone. Okay, so you have to give one SSRI. With that, you can give any of the mood stabilizers or antipsychotic. Better is to use quetiapine, you can use olanzapine, or if you can't give antipsychotic, you can give lithium, valproate, any of these. And then antidepressants are usually withdrawn within 1 to 2 months because of propensity to precipitate mania. Very important things, guys. Like if you don't understand these things, you will end up choosing incorrect option in your exam. Next, a 27-year-old man is brought to the office by his wife due to her concerns that he has not been himself for the last 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day, has no energy or interest in looking for work. So you have got 3 weeks, patient has not been himself, depressed, sleeping a lot, no energy or interest. Patient was hospitalized 6 months ago for an episode in which he became aggressive toward his wife. This occurred when she confronted him about staying up all night, gambling away their savings, investing a large sum of money in a startup company. So what was that time? That time patient had manic episode. Because that patient was hospitalized. Obviously, that was a mania. At that time, patient spoke very rapidly, had a brilliant plan to achieve world peace. So a lot of these things. He also experienced a similar episode 2 years ago. Which of the following medication are the most appropriate for maintenance treatment of this patient? So this is a bipolar disorder, bipolar 1. So you want to give carbamazepine and fluoxetine, lithium and quetiapine, lithium sertraline, lurecidone risperidone, valproate clozapine, valproate haloperidol. Always I say rule out the unnecessary option first. So carbamazepine is a mood stabilizer, fluoxetine is a SSRI, so it can be a possibility. So let's not rule this out. Lithium, quetiapine. Now, what about the depression patient having? We have to give some antidepressant also, right? So no, in here, nothing as an antidepressant. So cross this out. Lithium sertraline, this is one of the option and a good option, right? Because it has sertraline and a mood stabilizer. Lurecidone, risperidone, both are antipsychotic. So crossed it out. Valproate, clozapine, one is mood stabilizer, one is antipsychotic. So still no antidepressant. Same with valproate and haloperidol. So easily you can cross out the unnecessary options. You have A, you have C. Looking at this option, you already understand that lithium and sertraline will be the best option. Because carbamazepine and lithium, if you have to choose, we will always choose lithium because that's the common one and first line treatment. Yes, SSRI will precipitate mania if you are not giving it at the same time. And that's why you are giving an antidepressant and a mood stabilizer. So that's why it is not going to precipitate mania. But if you just give sertraline in this patient, yes, that will precipitate mania. And again, Dr. Add, MAO inhibitor is not commonly used. So forget about it. Do not choose any MAO inhibitor as an answer in the exam. It's very unlikely we'll never ever will give it. Because of it has a lot of side effect, and the good medications are SSRI, SNRI, then TCA, and then MAO. There is no difference. Bipolar depression is anyone having a bipolar 1 or 2 can have depression, right? Because that's a part of the diagnosis. So it's not like difference between a bipolar 1 and bipolar depression. Bipolar 1 means someone having full-blown manic episode with depression. Bipolar 2 means hypomania with depression. So every bipolar patient will have a depressive phase, and you don't differentiate between these two. Okay, Dr. Deki? Next, persistent depressive disorder or dysthymia. Mr. Smith complains of poor appetite, low energy, poor concentration, difficulty in making decisions, and affecting his ability to complete his assignment at work. These symptoms have been present for more than 2 years. Remember the dysthymia or PDD? PDD means patient having chronic depressed mood, mild severity for 2 years. And this patient usually get benefit from the psychotherapy. If you want to give medication after psychotherapy, you can try some SSRI. There is another disorder that is called cyclothymic disorder. Cyclothymic disorder means patient having many periods of depressed mood and many periods of hypomanic mood for at least 2 years. So that's just another kind of disorder in which patient having mild depression and mild hypomanic episode, but for most of the days for the last 2 years. That's called cyclothymic disorder. In this case, again, the good medication is to go for mood stabilizers, like you can try lithiums, carbamazepine, valproate, those medication. So we know about the dysthymia, we know about the cyclothymic disorder. Dysthymia, you can easily remember D for depression. Okay, and cyclothymia is the opposite one, which means both mania and hypomania for 2 years. Now, because we told a little bit about grief, right? So how we differentiate between a grief patient and a depressed patient? Grief or bereavement is the same term. So someone will be diagnosed of having just a normal grief or bereavement is that, like in the initial 6 months of losing someone, if someone feeling sad, tearful, decreased sleep, like a little bit of symptoms of depression, but not a full-blown MDD features, that's grief. But depression patient will have all the MDD features or criteria fulfilled. Grief symptoms, sometimes it get worse, sometimes it get better. But depression, it continues persistently. Suicidal ideation is very uncommon in grief patient, but depression, it's common. Grief usually gets better by 6 months. If even after 6 months, still patient having grief-like symptoms, then we call it as complicated grief or complicated bereavement. Treatment for grief is just supportive psychotherapy, like you send the patient to a counselor or psychologist for CBT. That's the only treatment. And depression, both psychotherapy and antidepressant. Next, a 50-year-old woman is taken to the hospital after neighbors find her wandering the streets, mumbling to herself and gesturing. When approached, she begins to cry and express thoughts about hurting herself. Examination reveals a scratch mark and also questionable lacerations on her throat. So active suicidal thought is there. When questioned, she reports feeling depressed since her husband died 5 months ago. She reports a decrease in concentration, feeling helpless, hopeless, anhedonia. Quit her job, staying at home. She now has begun to hear her husband's voice asking her to join him. Which of the following would be the next step in management? Begin a trial of antidepressant medication. Refer to psychiatry refer for electroconvulsive therapy, assess for thoughts about suicide, refer to the outpatient department for follow-up. Always remember, the most important thing for someone who you think can have suicidal ideation is to assess their thought about suicide. That is the next thing that you do. Because if this patient having active suicidal thought or ideation, you need to send this patient to the hospital and admit the patient. And that time, the patient will no longer will have just a grief. It will become a case of major depressive disorder. All right, guys, any question? All good. So let's move on to schizophrenia. You guys are okay that if I'm not giving you any break today? Good. All good. So there is a flow in the class. So let's just carry on. Schizophrenia. It's also a very, very important topic for your exam. Schizophrenia, so we discussed about depression, we discussed about bipolar disorder, grief, complicated grief. Now we are moving into psychosis. So schizophrenia is a thought disorder. And in a patient like this, they lose the touch with their reality. They don't have that ability to interpret their reality properly. And to diagnose someone with schizophrenia, the symptoms should be for more than 6 months. All right? No, this is a part of your course as well. This will not be repeated. Schizophrenia, the onset is at the age of 15 to 25. Very, very important is this prevalence. It comes in exam in a lot of ways. So what is the prevalence in general population? 1%. But if it is a monozygotic twin, it's a high risk, 47%. And this percentage comes in exam. Dizygotic twin, 12%. If you have one schizophrenic patient, 12% chance in the offspring or in the children. Two schizophrenic, 40%. First degree relative, 12%, very important. Second degree relative, 5 to 6%, like your grandmother, grandfather. So that this prevalence is important, you need to memorize it. There is no other way. Now come to the diagnosis of schizophrenia. To diagnose someone with schizophrenia, they have to have 2 or more of the following symptoms. So what are the symptoms that we have got? Delusion, hallucinations, disorganized speech, and the patient should have at least one of these 3. Grossly disorganized or catatonic behavior and having negative symptoms like flat affect. So what are these terms mean? Delusion means patient having abnormal false belief. And even though if you give a lot of information to the patient that it is abnormal, patient will believe what they believe. So it's an abnormal false belief which you can't make it true to the patient. What is hallucination? It's an abnormal perception. If someone is hearing some voices which you can't hear, that is abnormal, and that is what we call as auditory hallucination. If someone is seeing some things which you can't see, that's a visual hallucination. Someone can feel insects are crawling on their body, but you can't see anything. That's tactile hallucination. Okay, so you should remember these terms because that's how you diagnose these cases. And then disorganized speech. Disorganized speech means that you don't understand what this patient is saying. There is a term called loosening of association. Loosening of association means that patient with schizophrenia, like some patient with schizophrenia, you will not understand anything that they are saying. Like let's say you have said, where were you yesterday, John? And patient says, oh, my name is John. My grandfather was a very good man. My mom was there in the movie. Oh, that book was really nice. So what's happening in here? There is no association in between each of the sentence patient is saying to you. And that's what we call as disorganized speech or loosening of association. Saying so, loosening of association also comes under the term called derailment. And that derailment has two subtypes known as tangentiality and circumstantiality. Okay, so one is called tangentiality. And another is circumstantiality. Circum means circle, right? So what happens in circumstantiality that you ask a question to the patient says a lot, but eventually answer your question. So they circle back to the original question, but on the way to their answer, they say a lot of unrelated things. But in tangentiality, they don't answer your question. They just go on and on and on and on. So that's how we differentiate tangentiality and circumstantiality. These terms come in exam, so that's why I am taking a little time to discuss this. Next is your grossly disorganized behavior. Like disorganized behavior means patient is running in front of you. Patient is looking at the ceiling as if someone is talking to them, or patient is pretending that bugs are crawling in their body and they're just scratching their body. So any disorganized behavior, that's also a symptom. And negative symptoms means that a normal person should have a symptom, but this patient does not have it. So negative symptoms mean that a normal person should have a usual mood or usual affect. But patient with schizophrenia, they will have flat affect. That means whatever it is going on, they don't care. Like if there is a fire in the room, patient might just like sit there. They will not run away for their life. So that's called flat affect, which is very common in schizophrenia patient. Apart from that, they will also have social withdrawal. They will have poverty of thought. So a lot of symptoms will be there, but hallucination, delusion, disorganized speech, this is important. Patient needs to have at least one of these three. Sorry, not at least one, at least two of these three to diagnose schizophrenia. And the sign of disturbance should persist for at least 6 months, and that will affect their social, occupational life as well. So these are the sign and symptom of schizophrenia. Some of them are positive, some of them are negative. Positive means you can say added symptom, which normal patient does not have. So delusion, hallucination, thought disorder, disorganized speech and behavior, these are positive symptoms. And negative symptoms means that a normal person has symptoms, but this patient does not have it. Same like flat affect, normal person affect is normal, like usual affect, but this patient having a flat affect. A normal person will have a normal thought process, but this patient having a poverty of thought. Same like lack of motivation, social withdrawal, reduced speech output. So these are your symptoms of schizophrenia. One of the important things to rule out when you diagnose someone with schizophrenia is to rule out drug-induced psychosis. Like hallucinations can happen with a lot of illicit drugs. Marijuana, amphetamine can present as a psychotic patient also. So always rule that out first. Management. So management of schizophrenia is drug treatment. So you have to start drug treatment, which is your antipsychotic medication. And you start with initial therapy is either olanzapine or risperidone. And that's your atypical antipsychotic that is preferred. If response is inadequate in 3 weeks, then you increase the dose. If no response after 4 to 6 weeks, then change to another second generation agent. Like if you started with olanzapine, now you can change it to risperidone. Or sometimes first generation antipsychotic. We try not to give first generation because they have a lot of side effect, especially extrapyramidal side effect. What if patient with a psychotic one is very violent, agitated, removing the IV line, okay, or trying to punch you? What you are going to do? You can't give them oral medication. In that case, you have to go for some IM. So IM antipsychotic, the better one is either you go for IM haloperidol or sometimes you can go for IM olanzapine. All right, so chronic phase long-term antipsychotic usually is given to prevent any relapse. So long-term is also the atypical or second generation antipsychotic is preferred. What if it's a drug-resistant schizophrenia? Drug-resistant schizophrenia is if you try 3 antipsychotic as a maximum dose, and even after trying 3 maximum dose of antipsychotic, you can't control that or patient is not getting better, that is what we call as drug-resistant schizophrenia. The next option is consider a trial of clozapine. And clozapine is the last medical resort that you have. Even after clozapine, if it is not possible, then you go for electroconvulsive therapy. Why we don't give clozapine to a normal as a normal antipsychotic or a first-line one? Because it has serious side effect. But this is the best antipsychotic. But we don't give it because of its side effect profile. It can cause blood dyscrasias, so you can get pancytopenia, you can get cardiotoxicity, or if like a myocarditis, pericarditis out of it. So that's why it is very important that we only give clozapine as our last resort. Anyone with a clozapine coming to you with a chest pain, you should always consider myocarditis as your first line or first diagnosis. Do a ECG, do a troponin first. Nowadays, we choose risperidone as our best option. So if both options are there, choose risperidone. Medication. Now, side effects of the medication is also important. So antipsychotic medication can cause a lot of extrapyramidal side effect. One of them is called acute dystonia. So what is that? You started someone with antipsychotic and they're having bizarre muscle spasm, especially their face, trunk, neck. In that case, the treatment is just give benzotropine, IV or IM. Akathisia, patient is feeling very restless and it started just after starting your treatment. The patient is restless, can't sit for a long time anywhere. So that's akathisia. And in that case, the first thing that you do is to reduce the dose. And sometimes if even after reducing the dose, it is not getting better, you can use some propranolol diazepam or benztropine. Parkinsonism kind of symptom. patient with antipsychotic medication, they can develop Parkinson-like symptom, like they can get bradykinesia, like slowness of their movement. They can get tremor, and they can get a Parkinson-like gait. In that case, try to reduce the dose if you can, or alternatively, you can use benztropine or benhexal. There is another side effect known as Tardive Dyskinesia. It's an involuntary movement of the face, mouth, tongue, and limbs, but it usually occurs months and years after taking the treatment. In that case, stop the medication if you can. If that doesn't help, then you can use tetrabenazine daily as long as the symptoms are there. It does not come in the exam, so don't bother too much. But this one is important, neuroleptic malignant syndrome. This is a fatal adverse effect, and it can develop at any time during the treatment. Symptom is having a high temperature, muscle rigidity, altered mental status. Treatment, stop the medication immediately and give IV fluid. If it is life-threatening, you can give either dantrolene or bromocriptine. All good? So those are the side effects, or you can say extrapyramidal side effect of antipsychotic. The first generation antipsychotic like haloperidol, those usually give those EPS more than the second generation one. Among the second generation, risperidone can give the extrapyramidal side effect most of the time, but others usually doesn't give too much. No, you don't need to remember dose. Forget about dose for MCQ, even for clinical. Now, very, very important is this chart. Side effect for, like, it's not about extrapyramidal side effect. There are also some other side effect of these antipsychotics. And it comes in exam in many ways. Look at those: dyslipidemia, hyperglycemia, weight gain. These are the metabolic syndrome. Hyperprolactinemia, sedation. These are also some of the side effects. Now, let's start with the common medication that we use, olanzapine. Olanzapine is notorious to cause metabolic syndrome, which means dyslipidemia, hyperglycemia, that means diabetes, and also weight gain. They can also cause sedation as well, but not too much orthotic hypotension, doesn't cause hyperprolactinemia. Okay. Then come to the risperidone. Risperidone also causes dyslipidemia, but not too much like olanzapine. Same, it can cause hyperglycemia. It can cause sedation, very unlikely, and weight gain also, but the most common is hyperprolactinemia. So someone with risperidone getting galacturia, like whitish milky discharge from their breast, you should think that this is a risperidone which is causing this. Then come to the quetiapine, that is also commonly used. Quetiapine also similar like your olanzapine, it causes dyslipidemia, hyperglycemia, and weight gain. Not too much with the hyperprolactinemia. Another important one is aripiprazole. If you look at aripiprazole, it does not cause any dyslipidemia, no hyperglycemia, no hyperprolactinemia, no sedation, no weight gain. So that's a very good medication, but because it's not too much effective like others, that's why we don't use it as a first line. Then you have clozapine. Clozapine is similar like olanzapine. It also causes dyslipidemia too much, hyperglycemia. It also causes orthostatic hypotension, sedation, weight gain. Okay. Now the question comes for you. If you get a patient who is on risperidone and now having galacturia, what you should do next? Your next thing is to change the risperidone to aripiprazole, because aripiprazole does not cause any galacturia. Now, if aripiprazole is not in the option, then your best next option is to change this risperidone to quetiapine. Okay, very, very important for exam. Now, let's say someone is on olanzapine or even quetiapine or clozapine and having high blood sugar, having increasing weight gain, what you can do? The best option, again, is to change it to aripiprazole. Okay, so that's two of the most important questions for your exam. Now, when we change medication, especially one antipsychotic to another antipsychotic, do we just do it, or is there any other rule for it? There is a rule to change antipsychotic. What we do in here is that, let's say patient was taking olanzapine, and now you want to give aripiprazole. You will gradually reduce the dose of olanzapine, and then you stop it. Once you stop it, then you start low dose of aripiprazole and then gradually increase the dose. That is how you do the switching between two antipsychotics. Okay, so you taper off the previous one and gradually increase the dose of the other one. This antipsychotic switching, at the initial time, it should be in a hospital, because sometimes patient can get withdrawal symptoms and you need the patient in the hospital for the switching. So gradually reduce the dose of olanzapine and gradually increase the dose of aripiprazole. What if you want to switch antidepressant? In that time, you can't do this. Why? Because if you stop antidepressant today, in your blood, maybe another 2-3 days, antidepressant still will be there. And now let's say during that time, you started another SSRI. So your body already had the previous serotonin. Now you have given a new one, and you can end up having a serotonin syndrome. That's why to switch between two antidepressants, we give a washout period. And that washout period means a time between two antidepressants where there will be no medication. So let's say we want to change from sertraline to paroxetine. So what we will do, we'll gradually reduce the dose of sertraline and then we'll stop it. And then give a washout period of, let's say, it depends on antidepressant to antidepressant and their half-life. Let's say we are giving it for 2 days for sertraline. And then after 2 days, we start paroxetine as a low dose and then gradually increase the dose. So that washout period is for antidepressant, and for antipsychotic, we just switch the medication to gradually reduce the former one and then gradually increase the newer one. Is this good for everyone? Any question? Yeah, this recording will be given in our Facebook group also, because this is a trial session, free session. This will be available in the YouTube as well. And yes, the recording will be given in the software once you join the course also. What are the other psychotic disorders? One of them is called brief psychotic disorder. Now, everything is same. The symptoms of psychosis are there. But brief psychotic disorder means the duration of the symptom is more than 1 day and less than 30 days. So there will be hallucination, delusion, disorganized speech. So symptoms of psychosis will be there, but it is less than 30 days. For those patients, again, antipsychotic will be needed. Then you have schizophreniform disorder. Please go through these scenarios in your own time also to understand the topic better. Schizophreniform disorder, same. So patient will have all the psychotic symptoms. It's just the duration. So in this patient, duration will be more than 1 month, but less than 6 months. And when it is more than 6 months, that's schizophrenia. So now you understand if symptoms less than 1 month, that's brief psychotic disorder. 1 to 6 months, that's your schizophreniform, and more than 6 months is your schizophrenia. Again, for this schizophreniform disorder, antipsychotic medication will be given. Now, there is another term which we call schizoaffective disorder. That is a little confusing, but I hope you will understand it. Let's look at this term first. Schizoaffective. So this patient will have psychotic feature and affective feature. What is affect? Affect is your mood disorders. And what is your mood disorder? Depression and bipolar disorder. Okay, or depression and mania. So if someone having bipolar disorder and schizophrenia together, that's what we call as schizoaffective disorder. So look at this question. 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, I am making it easy for others to have sex with me since I know they all want me. So it's an impulsive behavior. She states she heard a voice telling her she was irresistible and everyone wanted her. So you have got hallucination. And also this one can be a delusion also. When she speaks, she can't focus on one topic at a time. So what is that? Rapid pressured speech, racing of thought, those things. Mood is euphoric, affect labile. So this one is mania. And the voice is your schizophrenia, or you can say psychotic feature. She recounts an episode last year where, although she did not have an elevated or depressed mood, she heard voices. And that lasted for 6 months. Now have a look that diagnosis is patient will have symptoms meeting criteria for major depressive disorder, manic episode, or mixed episode. So that means patient will have bipolar disorder feature, patient will have symptoms of schizophrenia, and delusion or hallucination for at least 2 weeks in the absence of any mood symptom. If you look at here, last year she heard voices, but she did not have any depression or mania. So that's your third criteria. Okay, so this patient will have both psychotic features like hallucination, delusion, and will also have either mania or depression together. If that is what you get in your question, your diagnosis is schizoaffective disorder. This patient might need hospitalization and then treat this patient with both antidepressant and antipsychotics. And the last topic tonight is delusional disorder. So Mr. Smith has been married for 10 years, and during most of those years, he believed his wife was trying to poison him to get his money. He frequently complains of a stomach pain, which he believes is due to the poison in the food. His thoughts are logical and coherent. This is a very important clue. He denies any hallucination. His wife, an independently wealthy woman, does not understand her husband's logic because she has more money than he does. Now, look at the question. His wife, he thinks that his wife is trying to poison him. There is a term for that. We call it paranoid delusion. If you think that someone is trying to spy on you, someone is trying to poison you or harm you, that is called paranoid delusion. This patient having delusion, but can we say that this is a schizophrenic patient? No. Why? Because at least two symptoms should be there. This patient does not have any disorganized thought or behavior. He doesn't have any hallucination. So only thing this patient having is delusion. And that's what we call as delusional disorder. And it is not schizophrenia. Non-bizarre delusion for at least a month. Non-bizarre means it's false belief, but somehow it can be possible. Whereas bizarre delusion means if I think that I have worm in my head, or if I think that I can see my soul in front of me, that's impossible. That's called bizarre delusion, which is mainly found in schizophrenia patient. Non-bizarre delusion, like, yes, there is a possibility my wife can poison me. So that's not impossible. So that's why we call it non-bizarre delusion. And the most important thing is that this abnormal belief will not affect their life. So it will not affect their social, personal, familial, or occupational life. Okay? And the treatment, outpatient treatment can be done. You can go for antipsychotic medication in this patient. Now let's say what you think about this case. A 37-year-old woman brought to the ED by the police after she was found trespassing on a famous film actor's estate. The patient is excited and says that this is all a big misunderstanding. She explains that she was only trying to leave the actor a surprise gift and note and would never harm him. She recently received a signed photograph in response to one of her letters. Keeps it in a box filled with newspaper and magazine about the actor that she has accumulated over the years. Patient says, for now, we need to keep our relationship secret so his wife won't find out. Although she has not met the actor in person, she is convinced that they will be together someday. Patient has worked for many years as an administrative assistant. Although she has no difficulty performing her job, she keeps to herself as she feels that her co-workers do not understand her special relationship. Mental status examination, she is calm and cooperative, speech non-pressured, goal-directed. Patient says her mood is wonderful because I am in love. Which of the following is the most likely diagnosis? Bipolar disorder, manic episode. We can't say it's manic episode because you can see speech non-pressured. Borderline personality, unlikely. We'll discuss about this personality disorder later on in our course. Delusional disorder, narcissistic personality disorder, unlikely. Schizoid personality disorder, unlikely. Personality disorder, they usually will be like very disinterested with others and lack of social life. So unlikely that this is the possibility. Narcissistic means bossy, egotic personality. Schizophrenia. If you look at this question, she has a abnormal belief about her relationship with the actor. And you can see that she does not have any difficulty perform the job. So it's not affecting her life. And you can see that there is no other feature of depression, no other feature of mania. So only thing that goes with this question is delusional disorder. Okay, so that's how understanding the basic is important. Otherwise, you will not understand anything that I'm saying. Let's say about how you feel about this question. 74-year-old man is hospitalized due to severe depression and a 9-kilo weight loss over the past month. Family members report that he has become progressively withdrawn from friends and family, stopped attending the games, refusing to leave the house, sleeps poorly, and also the patient has a history of depression, responded to treatment with TCA 30 years ago. Recent trial of SSRI has been ineffective. She has uncontrolled hypertension and MI 10 years ago. In the hospital, efforts to get him to eat are unsuccessful, and he barely drinks. Very important. On MSE, the patient's eyes are downcast. He gives brief, barely audible responses. So patient is going into mutism. He reluctantly discloses that he has been hearing the voice of his brother who died 15 years ago, also having psychotic features. What is the most appropriate treatment? Now, someone having severe depression like this, and you can see one of the important things that trial of antidepressant is already ineffective. And patient is not eating, drinking properly, having severe psychotic feature. You don't have any other option but to go for electroconvulsive therapy. So this is what I was talking about. It's the last resort. So, all right, guys, so that's actually the today's psychiatry session. I hope that you guys enjoyed the session tonight. Do you guys have any question? So usually the classes are 2 to 2.5 hours in duration. Most of the time it's 2.5 hours. So that's you should remember in the case. And also we take a 10-minute break in between so that we haven't taken today. So this is the psychiatry review session, but we will finish the psychiatry in our course. So the next class will be on some practice question solvation, some tips and tricks on how to solve questions. And there will be a 2 weeks free session starting from 6th of February. And that free sessions is for everyone. Even if you don't want to enroll the course, you can join the classes. And that classes is mainly on medicine, which is cardiology, and some question solvation as well. You will get the schedule in your Facebook group. Now, before we answer any questions about the course, I want you guys to see the video of our course. You will get all of your answers there. But still after that, if you have any question, just ask me. I'll be happy to answer here. So let's listen, or let's just have a look to the video. Sorry, guys. All good. So that's pretty much everything that I think that you need to know about the course. And someone of you asked that what are the days that, so we take a 3 days classes. 2 classes are mainly on theory sessions and another class is on question solvation. And the classes are on Sunday, Tuesday, and Thursday. And the classes are always it will be in the evening at this time, usually 8 p.m. CD time. And class goes on for like 10 or 10:30. If you want to join the course, you can email us to the email that has been provided in the Facebook group, or you can also directly inbox me in the Facebook group. Okay, if you're not in the Facebook group, please make sure you join it, because that's where you will get all the information. And this is a 5 months course, so it's starting from February, so just the ending will be in 5 months time, Dr. Fatima. Thank you, Dr. Aid. Nice to know that. So the video will be for an extended period of 10 months. Okay, so even after finishing the course of 5 months, you will get another 5 months as a recorded video. So it's a long time where you will get the access. And materials, any materials and questions, or all the prime mock tests in the software will be there as long as you pass the exam. And it's a $499 Australian dollar, Dr. Ali. There is no installation options. Yes, Dr. Fatima. Okay, so I can see that some of you are in the Facebook group. Do you guys have any questions? Anything that you want to know about the course? And try to join the Zoom session in the next class. So we'll see you on 30th January, and we'll discuss some tips and tricks of question solvation. And that's a very tricky one. So we'll go through that. And I would say, like, you guys should go through the JAM 8th edition. And in our course, we will start the 8th edition as well. So that should be fine for you. All good then. So thank you all. If you have any question, feel free to ask us in the messenger or email. We'll be happy to answer. Thank you all. Take care. And during this is a good question, Dr. Umayma. Like during this time when you are waiting for the course to start, I would suggest you to start with the handbook first. At least try to finish the AMC handbook, which is the blue book. And if you can finish it before the course start, that's a very, very good job, and you will be way ahead of others. All right, so try to do that at least. And if you already done that, you can start reading some important topics from JAM, which is in your handbook. And Dr. Sidra, we always do the recent questions. So you'll get 2021, even the 2022. So we always do our question solvation as a recent one first. All good. So let's finish it here tonight. Thank you, everyone, and take care. We'll see you on 30th February at the same time. Have a good